Good afternoon. Welcome to Psychiatry Grand Rounds today. The American Cancer Society is marking the 36th Great American Smokeout on tomorrow, Thursday, November the 17th. And it's our pleasure to coincide with the Great American Smokeout tomorrow for the topic of our Grand Rounds today, which would be nicotine dependence treatment for smokers with psychiatric conditions, engaging behavioral health providers. And we have two excellent speakers today joining us. Marty Frankhauser. Marty is a clinical professor from the Department of Pharmacy Practice at the University of Arizona. And she has been, well, Marty is retired now from the College of Pharmacy, which I'm very jealous of. But she's been involved in teaching medical students, residents, pharmacy students, physicians at large, and a lot of allied health professionals in aspects of pharmacology, psychopharmacology, and in the recent past she had become involved with the Arizona Smokers Helpline. Today also, for the second half of our presentation, the director of the Arizona Smokers Helpline, Stephen Michael, who has also been involved in a number of trainings to educate providers in tobacco cessation. In particular, of importance to us is the role of the clinicians in addressing tobacco cessation in folks with chronic mental illnesses. So please help me welcome Marty Frankhauser, and then she'll introduce us to Stephen Michael. Thank you, Marty.
Very good. All right. Well, I'm glad that we're here today, and definitely with the week of it, the smokeout, this is very good timing for us to be here. I am working at the Smokers Helpline right now as a pharmacist, trying to help people with behavioral health issues to stop smoking. And I'm going to talk a little bit, these are some of the learning objectives, but we're going to touch on some of the comprehensive tobacco cessation guidelines, a little bit about drug interactions that can happen when people start and stop smoking, which is very important, and some counseling ideas that are important that may address some issues related to people with tobacco use. And then we are going to talk about the Arizona initiative that happened, and again, we have a grant that has been going on. It'll be ending in this December, but we are having some Arizona input and trying to help people with mental illness to stop smoking. So overall, when you think about tobacco use, it is a tremendous problem because of nicotine dependence. Now, nicotine, we'll talk a little bit about biological reasons, but it's quite a chronic illness that has relapses, just like any kind of mental illness or dependence problems. And we know that anybody that is around cigarettes, that means smokers and those that are getting secondhand smoke, have a large amount of people die each year. In fact, the statistics are 440,000 people per year, and that is 1 in 5 deaths in the United States are related to tobacco use. So it is, as we always say, the #1 preventable cause of mortality and morbidity in the United States. And it requires treatment. We're going to talk a little bit about approaches, but from the ASH line, we provide a free service to anybody in Arizona to help them, and that's really one of the efforts we have today. So this is what happens when you look at people that smoke. You can look at this picture and say it can cost in the United States $193 billion a year in health-related or loss of work. It extends on, but can you imagine if we were able to solve some of that problem, how much more money we'd have for health care? And we can prevent so many chronic illnesses if we are able to do that. There was a recent 2010 assessment of smoking, and we're very fortunate that Arizona has one of the lower rates. If you look at the little dotted area down here, you will see that we're in a lower rate than some of the other states, and we'd like to think that's because our state takes it seriously, and I do think that we're trying very hard to keep people from using tobacco. But the problem with this, even if you look at these statistics, they look great compared to what it used to be in the 1960s. And in fact, back then, I couldn't believe it when I looked at this. In 1965, the adult smoking rate was 42.4% of our population. So we now are half of where we were. So that says a lot. And the reason for reductions has to do with mass media campaigns. We now have medications that can help people. We have all kinds of treatment venues. And the biggest thing I'm going to talk about today is getting medical providers more active in this. You'll be surprised that we can do a lot more. Who smokes? Men are higher than women overall. And of course, there is a difference. If you look at the bottom, Native Americans have the highest rate compared to Asians. So you can see there is an ethnic difference, probably by who you're brought up with and your family. And this is the sad part, that if you look at who's smoking, these are people below our poverty level. And we'll address this because this is where psychiatric patients are often sitting. They are, as you know, we'll talk the statistics, they're using most of the tobacco products, and they are more likely to die from tobacco use. And people will use a lot of their income that they have to buy cigarettes. So it's some big problem that we have to deal with. I think the problem I see is that the 99 or almost 90% of smokers will start by the age of 18. And how can we reach young people? We'll talk about some national campaigns that are going to try and do that. But it's very good that if you look into 2010, the rates are coming down. But by 12th grade, they are up in a level that means these could be lifetime smokers. And at this age, people don't see death and morbidity issues. They think it's cool and their friends are doing it. But this is where the majority of people start smoking, and 6 million of those people, will die prematurely. When I do counseling with patients, I always talk about the acute effects because it's important if they're not quite into the chronic effects where they're at. And again, I'm not going to talk too much about this, but even pregnancy is one that is a very significant. If a woman smokes during pregnancy, there's a high risk for all kinds of problems in the fetus. And low birth weight babies, it's a population that we need to tackle as far as getting women off of tobacco during pregnancy. It'll cause impotence, infertility, and of course carbon monoxide, which is going to end up in cardiovascular disease. These are all the long-term problems, and of course the ones like lung cancer, cardiovascular, heart attacks and strokes are the ones people die from. But the COPD, I do quite a few phone calls now. People have trouble breathing. They're on breathing things now. They have high blood pressure. They have a lot of symptoms. And in my experience, the people that are the most interested are in their 60s. They just see they have some years left and they want to stop smoking. But often, we're talking about people who smoke for 40 years and have not stopped. For psychiatry, I think it's important that these are all risk factors for psychiatric disorders. If you are a smoker, you're going to have a higher risk of having mental changes. And the one that I think people don't realize is you will have cognitive difficulties. Dementia is definitely related to people that had smoked, and it decreases their ability to have cognitive decisions and, of course, have disability. So there's a lot of problems, and this is where the healthcare costs start adding up because people have so many chronic illnesses and treatments and multiple physicians now involved with their care. And the problem is, we'll see, is when you get to these states, are we helping anybody to stop smoking? Are the medical profession going forward and talking to people? A little bit about environmental risks. They predict or think 50,000 people die from environmental toxicities related to tobacco use. And of course, anybody that's exposed to it, if you have a parent or anybody that smokes, you're going to have a higher risk of having even the lung cancer and heart disease. And it has a tremendous impact on children. We mentioned birth rate, but SIDS is involved, asthma, middle ear infections. And if you are in a family that smokes, you will have a higher rate of smoking. That's almost been shown to be correlated. I'm going to talk just about some campaigns because these are in the news, and it's always good to figure out where we are with the government, because the FDA just is going to put in $60 million on trying to talk about the dangers of tobacco use and trying to reduce our rates way below 20. They're going to be doing some public education. They're targeting youth, minorities, military, gay community, and they're going to be doing more ads on TV and print and social media. And you probably all heard about the cigarette packets getting these nice diseased lungs and things on the packet. This is supposed to start in September of next year, and 5 of the tobacco companies have sued, and just recently, November 7th, a judge basically blocked the ruling until they could see if it was constitutional. The reason I could see that the companies didn't like it, it was going to cost them money to change their packaging, and because they didn't want to spend money on it. So some countries are going to just an all-green color, a unicolor, not putting pictures on it. So there's enough evidence that when you look at a pack of cigarettes and it has some kind of visual effect, that it does make you think twice. So we'll have to see what happens with the packaging. Hopefully you've all heard about the Million Hearts campaign that is also by the Department of Health and Human Services. It just was announced in September. It's part of the Healthy America, or for 2020, trying to get people in more healthy states. And they're trying to prevent at least 1 million heart attacks or strokes. And if you look for where tobacco use is, it's one of them. You can see on the list trying to reduce tobacco use. They think about 25% of people with heart attacks, it's related to tobacco use, and about up to 20% of strokes is related to tobacco use. So we're part of this campaign mainly because of the health care costs, and also because this is preventable if we can help people. And so you can see that they're basically going to be doing a lot of campaigning, so you'll be seeing more of that. In fact, I've even seen our local public health department start some of the campaigns for healthy eating. They're already on our TV, and it's a nice reminder. I like the ones where the children are reminding the adults to get up out of watching TV and, go plant a garden. So they're trying, I think, to instill changes in all health care. I wanted to mention this publication. There's a PDF file of it that's listed, but it's from the Legacy Foundation, and this was published this summer. And what I like about it is it's probably the second publication, but the newest one talks about the issues related to why it's an epidemic in our mental health clients, but we're not doing a lot about it. And it's very much talking about the barriers for why nothing's happening. And if you read these two lower, one is that they feel that we need to do more education and training of mental health providers in evidence-based tobacco cessation. A lot of people have no idea how to help people. They're not educated on the products that are available, how to select a product, how to educate a person on it. I always like the thing they say, well, just ask your pharmacist. Well, it really should be at the medical provider, because there are going to be changes potentially in drug levels if they're on medications. You want to be involved with helping the patient. And then the second part is just integrating tobacco prevention and cessation in mental health care. And so those were some of the barriers that they saw that were out there that we needed to work on. So the Legacy is sort of reminding us what we need to do, how we can get moving forward in this. I'm not going to talk about each one of these, but there are available things in PDF files that you can pull up for in mental health settings, toolkits that are available. Some of them get updated. These are the ones that are most commonly looked at. And I want to mention UCSF Education and Training. The RX for Change is a program. You can go on their website. They have educational programming. They have slide sets. And if all of you picked up the this came from a conference that we did October 15th, and we had extra packets. But Jody Prokowska, who is one of the people that works there, came to Arizona to give this talk to medical providers. And on the right-hand side of this packet has some RX for Change materials. It has her handout, and also Stephen Michael gave a talk, and their PowerPoint presentations are here. We had extra ones, and we wanted to share with you what is available. But it's a great website website, and they have some of the best training materials that are free, so you can definitely go on. The other thing that I just wanted to talk today about, we talked about barriers and why aren't we doing more. And these are some old statistics that came from 2008. I hope in 3 years we're doing better. But I do agree, when I look at treatment plans and I look at DSM axis, I rarely see nicotine dependence even listed. It's usually not in their axis. And often in smoke-free environments, people are not even asked about getting a nicotine replacement product. And I know this has happened. I think it was 2.5 or 3 years ago. I asked both UMC here and UPH, which is then Keno campus, how many nicotine patches were they using in the whole hospital per month. And at UPH, at the Keno campus, they were averaging 25 nicotine patches for a whole month for all the patients that went through that hospital. Because we have a Pyxis system, we can count them. Here at UMC, they couldn't even tell me. They didn't even order more than, not very often. So all I could tell is in the pharmacy, we weren't seeing patches being taken out to offer people. I think things are better now, mainly because people that go into nicotine withdrawal, we'll talk later, have a tremendous problem with behaviors, agitation, aggression, and often we misdiagnose that. You give the wrong medicine to treat the aggression, and when really a nicotine patch could have sufficed. And then only 1 in 100, this was smokers in inpatient psychiatry units, were even encouraged to stop or provided NRT products upon discharge. The other thing is they've done a couple of studies looking at psychiatrists. Do they participate in helping people stop smoking? And this is one study, 12% versus 38% of people in primary care physicians was one survey that was done. This was another recent one where they looked at family practitioners versus psychiatrists. So psychiatrists at about 62% would ask about smoking. Only 14% would arrange for it, and only 2% would refer to a quit line. And I'll have to tell you, I worked at the quit line for quite a while now and looked at who is referring patients into for help, for quit line services. And it's very disappointing. I'm just amazed that we're not doing better, particularly when this is a free service and, we can help people provide education. But we do know that psychiatrists, you would think would be at the forefront, and they're not. Family practitioners, often when people have medical illnesses, are when people are encouraged to get help and to stop smoking. This is another embarrassing slide. I asked them to pull the Ashline referrals from all the hospitals in Tucson for this from January to October. And you can see the red up here is St. Mary's. The blue is St. Joseph. Carondelet went smoke-free several years ago, and they have made some steps forward, I think, just because of that. We now have the South Campus is the sort of the yellow one, and you can see they're doing a lot better. We have UMC. This is our campus right here. 1, 2, 0, 0, 0, 0. This is the hospital we're in right now. This is anybody at our UMC that could send a quick fax or send it over to the Ashline. So do you think we still have a problem? Okay, so we have a huge problem. People that are admitted into a hospital through emergency room, they should be the #1 because I'll tell you later, a lot of people that smoke are admitted to hospitals for cardiac, heart disease, you name it, and it really is something that we want to see these numbers go up. So what about our population? I just want to talk briefly about it. 22% of people in our adults have some kind of chronic mental illness, and that's a huge amount of our population. Can you imagine almost 1 in 4 in the United States have a problem with mental illness, and they have 2 to 4 times higher rate of smoking and being nicotine dependent. They consume about 45% of all tobacco products. And then they spend, some studies are saying up to 40% of their income is going to be on cigarettes. So you know they're not putting it in on nutrition, on things that are healthy. They're using more tobacco. And I don't have statistics on caffeine, but I think another % of their income goes on caffeine. It's amazing how many people are using both caffeine and nicotine. We know patients with schizophrenia have a higher rate. In fact, they're some of the highest users. Bipolar disorder, you can read through the different disorders, serious psychological distress, ADHD, dementia, and then if you look at the general population at about 20. So people with schizophrenia have at least a 3 times higher rate. Some of the studies have shown much higher than this. This is one that I just had the most recent data. And if you look at who is smoking and who has mental illness, it goes to 7% of the population is who we're talking about. If you are nicotine dependent, you have 2 times the risk of being depressed. In fact, if you are a smoker, I do not think you will ever respond to traditional antidepressants as well. I think we expect way too much from these medications, particularly when people are using tobacco products. And anxiety is a tremendous risk factor. In fact, daily smoking is a risk factor for panic disorder, panic attacks. And if you add caffeine on top of that, you can imagine what anxiety. That's why I see the patients, how many people are on benzodiazepines, on drugs to counteract the stimulants. It's a very common thing to see polypharmacy in these patients. And I already mentioned schizophrenia, patients with schizophrenia, 50% of them are heavy smokers, meaning they smoke over a pack a day, and they're more likely to use high-tar cigarettes than other people. And in nicotine dependence, we already talked about this, but they have the highest mortality rates because they're the most heavy smokers. So if you have mental illness and you're smoking, you will die approximately 25 years earlier, which means a 28% shorter lifespan. And again, it is the most preventable cause of death if we could get people help. This is just some statistics on schizophrenia. We've already talked about cardiovascular, respiratory, other risk factors. We now know that some of the people on these medicines or psychotropic drugs are having problems with obesity. They tend not to eat well, they're not moving a lot, and they have very poor health. And they're more likely, light smokers, to have more positive symptoms of schizophrenia, meaning hallucinations. They may have less EPS because dopamine sort of counteracts the shutdown of dopamine by antipsychotics. They're more frequently hospitalized. In fact, Jody Prokowska gave us some data on that, that if you see patients coming in and out of the hospital, besides substance use and abuse, they are definitely our nicotine-dependent population. So whenever you see patients coming in the hospital for psychiatric conditions, you want to assess that. They have higher rates of suicide risk, and things like polydipsia. Some of the patients have a drive to drink lots of water, and this is definitely higher in that population. Alcoholics have a 10 times higher, if they're smokers, to have pancreatitis, having higher rates of cirrhosis, and of course developing, look at the rate for mouth and throat cancers, which is very, very high. And as I mentioned, smoking is not good, but if it really is damaging the brain, and people that are alcohol dependent probably don't eat well. There's a number of factors for this, but they have an increased risk of having brain damage and sort of conditions like dementia. And you can see this happening over their lives, that their cognitive abilities go down. Jody Prokowska, who we were just talking about, just published a new study. It was just out just within this last month, and it had to do with bipolar patients. And many patients, in the survey, this is an online survey, said that they were using tobacco products to treat symptoms of their mental illness, that most wanted to try to quit. And the one thing, right, again, few were advised to quit by a mental health provider. And many times they made multiple attempts to quit but had no help. They were basically unaided. And that's one of the things I'm very aware of when you look at the statistics. Many people are trying to quit but without any help, such as counseling, coaching, and or of course using medications. And by quitting smoking, it improves their whole mental health picture. It is one of the most positive things you can help somebody with. And I always encourage patients when I talk to them by phone, you know, by quitting smoking, your psychiatric illnesses will probably get better. You're going to function better. You're going to sleep better. You're going to have less anxiety. And there was one good study recently is you'll be a nicer person. You're less irritable. And people will like you better. So I sometimes have to throw that in, particularly when people say, my spouse just can't stand my attitude and my smoking behavior. The other thing to remember, people that use substances also are high nicotine users. And if you look at substance abuse treatment facilities, 75% of people are using cigarettes. They have other substance-related disorders. And the thing is, if you can stop smoking, these are people who have other substance use, you get a 25% increase in the long-term abstinence from alcohol and illicit drugs. You know, we send people to AA meetings, and they're smoking away, right? And if we could get them to stop smoking, it would impact on their alcohol use, that those things are tied together. And they do talk about incorporating a smoking cessation into any substance abuse treatment program, and it will not hurt their recovery. And even 12 studies have said if you can just eliminate tobacco use, you will decrease the use of other abuse substances. Now, why isn't this on our radar screen? You know, you'd think if this was it in substance use. In fact, I just recently went to another talk on this, on substance use, and nicotine got about a 2-slide presentation, right? It just is not on people's thought process that that could be the #1 thing to start out with, because it will impact on other substance use. And also, I also want to mention, if people stop smoking, because of the enzyme involved, caffeine levels will go very high, and you can end up having almost like caffeine toxicity when people stop smoking. So there's a lot of I always say I think caffeine is the most common co-occurring substance that people are using along with nicotine. So there's problems, comorbidity issues just with substance use. We know that's a huge problem with our patients. Often they're self-medicating to prevent nicotine withdrawal. We'll have a slide on that in just a minute. And then the things about nicotine, it can enhance people's concentration, learning, mood. The net effect of nicotine is pretty powerful. Also, whenever you smoke, not only does dopamine get released, but also the endorphins. And so those are two substances people can get very dependent on. Endorphins can sort of calm people down and also make people feel, have less anxiety at times. They can reduce medication side effects, particularly atypicals or typical antipsychotics. People will report less EPS. They will make underlying psychiatric conditions worse. And there's just a recent study that they've shown that cocaine, and this is in mice, not in humans, but is definitely a gateway drug into using drugs like cocaine. So people that are tobacco dependents also go off and use other CNS stimulants. So there's a lot more education we could do. I just wanted to mention there's definitely, when you look at tobacco use, there's a biological, psychological, and a social cultural, and each of those have to be addressed. That's why when they come in, and of course with the ASH line, the coaches start addressing all of these symptoms and things that people are you know, what's their home-like life, when do they smoke, do they have people in their homes that are using tobacco products. But for the biological part of it, we really know that what we're dealing with is nicotine dependence, and it has the same comparable dependence to other drugs like cocaine and heroin. It has the same kind of repetitive. And of course, nicotine is very short-acting, so that's why people have to continue to keep replacing it every 20, 30 minutes, usually. And I already mentioned it impacts on many kind of neurotransmitters, but dopamine and the endorphin systems are ones that people can get very dependent on, that boost of neurotransmitters. And the changes can cause long-term problems. Even any kind of brain, anything you put in your brain can cause changes in functioning. I just noticed this week they talked about marijuana use and the impact on brain structure. So any time you're using any kind of substance, you're going to cause probably long-term issues. And then these patterns of addiction start being to be learned behaviors, so people have to learn how to resist some of those temptations when they get into those states. Nicotine withdrawal is a very well recognized problem. I mentioned within the first day after abruptly stopping smoking or stopping nicotine, there is a biological effect in the body. Within 2 days, it usually will somewhat peak, but within 2 weeks, you can still have symptoms. And half of the smokers down here report at least 4 withdrawal symptoms, and usually it's anger, anxiety, depression. Those are the symptoms, and they may have other symptoms. Irritability and aggression is very common. And this last year at University of Colorado, Dr. Allen published a paper that was very positive on people with schizophrenia coming into emergency room. If you patch them with a 21 milligram patch, they had less aggression, less behavioral problems. The problem with that is a 21 milligram patch will only cover about a pack a day. 1 cigarette has about 1 milligram, and a pack is 20, so a 1 patch at 21 milligrams may not cover people that are high tobacco users, and you have to add on other kind of nicotine products. Some people require 2 patches of different strengths, let's say, to cover the nicotine so that they don't go through withdrawal. Also, we have to worry about liver enzymes. The 1A2 liver enzyme is a one that is increased with smoking. It has nothing to do with the nicotine, but it's the contaminants in the smoke that kicks in the liver. And there are so many medications that are metabolized. One of the positions I have right now is I have people review all the medicines they're taking and do some counseling. If a provider sent the patient into us, I'll communicate back with them on what medications can be impacted by stopping smoking. And mainly it's because their levels will go higher. And many of the antipsychotics, antidepressants, you all recognize duloxetine is Cymbalta. It's probably one of the most commonly prescribed antidepressants now. And many of the antipsychotics, carbamazepine, some of the benzos, we already talked about caffeine, but even things like acetaminophen can be impacted. And by the way, if you're a smoker, you will get rid of estradiol and testosterone. People that smoke often have lower levels of hormones in their bodies, and I always wonder if that's why they age so more rapidly, because you don't have the hormones in your body at that time. So when you stop smoking, you're going to increase basically the levels of medicines and can cause side effects. So there are some guidelines. This is one of them that the U.S. Public Health put out for why we need to be involved. These are just examples of psychiatric disorders saying clinicians must overcome their reluctance to treat this population, that you need to incorporate this in your practice. You know, stopping smoking may have withdrawal that you need to think about, and also that it can affect the pharmacokinetics. So in this book, it's guidelines for clinicians to use to help us make better decisions. They have information on things like antidepressants. Bupropion is FDA approved, nortriptyline is a second-line antidepressant, but that people with a history of depression do much better if you treat depression, and be sure that that's not a problem when they stop smoking. And in many people, you can combine treatments like Wellbutrin bupropion, which is marketed as Zyban, with NRT products, and actually people with schizophrenia do very well with these kind of combination treatments. This is an example of treating somebody with schizophrenia, being sure they're on an antipsychotic, but if you look at these, 2 of these are going to be impacted by stopping smoking, clozapine and olanzapine. So if in this state, you know, if you're going to stop smoking, you have to realize the blood levels will go up with those 2 medications. Bupropion can be used, nicotine replacement therapy. If they're heavy smokers, you can start mixing things like a high-dose patch with gum or lozenge, and mention bupropion with NRT, and again being sure that they get supportive help or counseling. You all know that we have some problems with varenicline and bupropion. Both of them have black box warnings now for neuropsychiatric events. Just to let you know, there was a recent one published just in the last week in November by Moore and this group. They must be going through all the data that was ever sent to the FDA because that group is involved with publishing some of the things. And again, they looked at varenicline versus bupropion, and they said that it had a significantly higher rate of depression, suicide, self-injurious behaviors compared to bupropion. Also, you probably hear people will talk about bizarre dreams, abnormal dreams, and that's usually because we're giving, the dose is given during the sleep, at the end of the day, and it's there during the sleep cycle, and your dream state is driven by dopamine. That's what runs REM sleep, and this drug probably increases those bizarre dreams. And then recently, there was, again, a warning on cardiovascular events with people with pre-existing cardiovascular disease. So we have to really screen our patients. Today I talked to somebody that had a head injury and had seizures in the past, and of course that you automatically think, well, Wellbutrin or bupropion is not going to be good for that patient. So those are some adverse effects. So what is important besides referring? I think everybody that is seeing patients needs to do something beyond just, drug, alcohol, mental disorders, need to get that counseling involved. And this is just a list of some of the things that we work with people talking about exercise. Exercise actually promotes dopamine and endorphins. That's why I always tell people if they just get up and move, they're going to be discharging those same chemicals in their brain as nicotine. And again, they have a decreased risk of all these other medical illnesses. I've been sending out a lot of information on healthy eating and what kinds of foods people can eat. And the main thing is, I think, is just being sure you're talking about it. If you are tracking people long term, there's an advantage to continue bringing it up if they're not ready. Always talking about the benefits of stopping smoking, and if they've had any previous attempts, what worked, what didn't work. I'm always surprised how many people didn't use the product correctly. When I go over it, I find out they tried it, but they didn't use it the right way. And again, sometimes they're afraid of things like gaining weight or other things that are happening. So I think the main thing I'm going to tell you is to get involved. I hope I've convinced you that we have a problem, that there's a lot to be done. And the Ashline, I'm going to have a little bit about that now, because we teach ask, advise, and refer. And refer, again, means refer for treatment or help or support. So I'm going to ask Stephen Michael to come up. I'm really happy that he could come here today because he's been involved with the Ashline, I think it was 2006, has been the director, and again has been very much involved in promoting this initiative in Arizona, and is very active nationally to work with national programs. So Stephen, I'll give you the podium.
Thanks. I appreciate you having us come and talk about what we're doing. I'm going to cover kind of the landscape of what's going on in Arizona and how, as clinicians, you can be more involved. This has always been one of my pet projects. I've been working in behavioral health for over 20 years now. Started with adolescents and then moved into working with folks with chronic mental illnesses, and have worked on the national level on many of these issues, tobacco being a current one. I currently serve on the advisory council for the North American Quitline Consortium, and this is one of the top areas that we're dealing with currently is whether Quitlines should be providing these services or not to people who are diagnosed with chronic mental illness. One of the things that's, I think, important for people to recognize is, as Marty mentioned, there was that report in 2006 that came out that showed that the mortality rate was 25 years reduced for people who smoke and have chronic mental illnesses. And Arizona actually is at the top of that list at 31, not in the right direction, but had the worst outcomes. The state recognized that, so the Division of Behavioral Health now has made it a requirement on all the system of care plans for the regional behavioral health authorities to reduce tobacco use by at least 15% in the next 3 years. The advisory group that's working with them, there's a grant from SAMHSA to work with the people at at the University of California, San Francisco, to actually put a plan in place here in Arizona. Our goal was to reduce it by 40%, and the division thought that was a little aggressive. We're still hoping, though. And speaking of the Behavioral Health Initiative, the Bureau of Tobacco and Chronic Disease started working with the ASH line to really talk about how can we impact this population, because the smoking rates are so high. We recognized that if the math was done correctly, if we could get half of the people who smoke, who have a chronic mental illness, to quit, we could reduce the overall prevalence in the state of Arizona by at least 2%. And that was pretty staggering considering how long it's taken to get things to go down. So they've started this behavioral health initiative, which really was to first focus on the people in the mental health system who have a diagnosis of chronic mental illness, try to get some systems in place, and then use those systems also for people who have substance abuse disorders. But we didn't want to tackle both at the same time. That was a little too grandiose for us. There really isn't enough money in the state to do that yet. And then really develop an integrated model that provides access to tobacco cessation in multiple facilities, not just through the quit line. Although we represent the quit line and we provide this service, we want to recognize that behavioral health facilities should also be providing tobacco cessation services. So what the initiative looks like, this is actually a graphic that is used for the whole tobacco initiative in the state of Arizona to really look at involving multiple different arenas to get people to quit smoking, from social networks, incorporating marketing and media, getting county partners involved, really working heavily with service providers and clinicians, and then also using those quitters themselves once they quit or relapse to influence other people to quit smoking. So our focus is really on getting the service providers involved, because what we found, research shows that if a healthcare provider tells somebody they need to quit smoking, that is the #1 reason people will make their first attempt. So we need to get more healthcare providers encouraging, not just asking if you smoke, but encouraging people to quit and providing direct services if they have the time and willingness to do that. We often ask, and I'm asked this, why should we use a quit line? Why include quit lines in anything? #1, they're required by federal mandate, not by a law, but by mandate. Every state's required to have one. Unfortunately, every state's not required to fund it. So some states have very low funding. Arizona, we are very fortunate. We're one of the few states where our tobacco dollars are voter protected, and currently the legislature hasn't been very lucky in taking that money away. They've gone after it a few times, but they haven't taken it away yet. So we're one of the few states that still has dedicated funds for tobacco cessation. So a lot of that money now, even though we see a reduction in Arizona, is now being put towards quit lines in Arizona in particular. There is a national quit line, the 1-800-QUIT NOW, that could be used for anybody. If you call it, it's just a portal. So depending on the area code you're dialing from, you'll get the state for that area code. Cell phones have made this a little more difficult. So some people don't get the right state, but all quit lines have all the numbers for all the other quit lines. So we can always get you to the right one. The other thing that's been documented very well in the literature is that quit lines work. By adding behavioral support, you anywhere from double to quadruple the chances of a person staying successfully quit. But not all quit lines are created equal. One of the things, as I was saying, no state is required to fund them, so there's different levels of quit lines, and there's a big push right now to recognize the comprehensive quit line. It's not really an intervention all by itself. It's kind of like a portal, a place you can go to get multiple services. So a comprehensive quit line like the ASH line, we provide inbound telephone call support, so people can call in, they can enroll in the service, or they can just call and ask questions if they want. We'll provide self-help materials if they want them. We have a website that has a built-in quit plan for them. Some people don't want to talk to a human being, so we set up kind of our process in an online fashion so they could also do web-based quit planning if they want. We also provide proactive multi-call programs, and this is where the person actually enrolls in a program. They get assigned a coach. We call them quit tobacco coaches because they really focus more on helping that person in this one focused area. We don't do psychotherapy in any way. But we do have on board 2 licensed behavioral health therapists, so that if we do have people with complicated issues, they can work with those therapists, and then they also work with Marty on their medication issues. And then medication assistance is always a big one. Many of the states don't support medication assistance. Arizona, we just happen to be in a state. We have 2 venues for medication assistance, which other states don't have right now. And currently, because of the CDC grant that we have to really work with the behavioral health field, we have Marty on board to provide pharmacist assistance. She does reviews with the patient and then also provides feedback to both the psychiatrist, any of the prescribing docs. If the patient will give us permission, we'll provide the feedback to any of the prescribing physicians. And we try to get permission to do that, because one of the things we do find is that many doctors are prescribing, sometimes not knowing what other doctors are prescribing. There are 3 ways to actually get involved as a provider. The easiest one to get started, and you have it if you pick up one of these packets, is the QuitFax referral form. Once you fill this out once, all of the key information, and University Hospital, although they were the last hospital to come on board in Arizona, they do have this on file now. So you should have these on your units where you can make a referral directly from a fax form. We also have a web-based system where you can make referrals. You can log in, get yourself set up. And we're working with some hospitals to build into their in some way electronic health records, a way to make referral. UPH South, or UMC, what do we call it now? UA South, actually has it built into their health record. It's not completely seamless, but at least it's built into the electronic form, so they can make the referral. It goes one place, then they fax all of the referrals over to us. So we encourage everybody to get involved in a referral program. If you don't feel like you have the expertise, or you just don't feel like you have the willingness to get involved with your patients, you can always make the referral, because our folks, that's all they do, day in and day out. In Arizona, we're lucky to have 2 ways to get medication right now. For people who don't have insurance, or currently if they have private insurance that does not cover medication, we'll provide them with 2 weeks of nicotine patch gum or lozenge. It's not everything people need, but it at least gets them started. Those are mailed directly to their homes. And then in Arizona, the Medicaid program, the Access program, this is now mandated by law. Access needs to provide 12 weeks of any of the FDA-approved quit medications. So any of the 7 medications, any person who is Title 19 Access eligible and has, even if they're eligible and going through the process, they can get, all they need to do is get a prescription from their primary care provider. Unfortunately, we're working on changing the law so psychiatrists can be involved in this, but it needs to be a primary care provider who does it right now. And they can get 12 weeks of any of those. And they can get it twice a year. This benefit is twice a year. It's not a one-time benefit. So every 6 months, if they relapse, they can use this benefit. Our message when I go out and train, again, this has been one of my pet areas for years, and I've been trying to encourage this reduction in tobacco use. So this is the message that we like to get out there. The tobacco cessation is a treatment issue. It is not a lifestyle choice. We still hear a lot of physicians out there who talk about cessation or tobacco use as though it's a choice people make. And yes, they did make that choice at some point in their life, but it's an addiction, and it needs to be treated as an addiction. One of the things I often ask, especially mental health providers, because we still hear this, I'm waiting for the year where I don't hear somebody call and say, oh, well, I have this client, and their case manager told them that now is not a good time to quit. Their psychiatrist said now is not a good time to quit. And the example that I like to use is if you had a patient who came in and sat down with you and said, Doc, I really want to quit using cocaine. Are you going to stop and say, oh, now's not a good time for you to quit your cocaine? It needs to be treated the same way. It is an addiction, and it is a treatment issue. And this is actually from Dr. John Hughes, who's in Vermont, uses this one as an example. You don't allow people to drink or use illicit drugs on campus. Why are you letting them use tobacco? It's more deadly than those, and it affects other people. And people with mental health challenges really do want to quit. The research shows that there is no difference between people who have been diagnosed with mental illness and the general population. Still about 70% of all folks want to quit, and of that about 80% will make a quit attempt. So about 50% of people every year will make a serious quit attempt. What we need to do is get them the help they need. And then you can do that through referral is the easiest way. And here's our mission. You've got this on there. The Ashline's mission really is to improve health of Arizonans by providing the client-centered tobacco cessation services through technology-based interventions. So Marty and I are going to take some questions while we have some time. We don't want to keep you too late. got dark. There's people
Very
back
dark.
there somewhere. Anybody have questions? There we go. Question about tobacco? Questions about anything? Quiet group. Is there any particular approach to direct lack of motivation?
You tell them and explain to them why it's important to quit smoking. They're not motivated. I mean, they may not be motivated. I'm wondering how you deal with it.
Well, one of the things that we look at is if you ask them every time they come to see you, you're going to catch them sooner or later. 70% of people every year want to quit. The idea is if you just keep asking them, sooner or later you're going to hit them at a time when they go, you know what, maybe you're right. This time I'm going to try it. Dr. Xuan Zhu at UCSD in San Diego, he did a study that kind of shocked him because he's a psychologist. So he's really into quality of care. But one of the things he realized in doing this study is we really need to get more people just to make quit attempts. The more often they quit, the more likely they are to make a permanent quit. So one of the things, his big push now is from a public health perspective, you just need to get people to make that quit attempt. And it was hard for him to say this, working with the quit line. Regardless of how they do it, they just need to make the effort to quit. So asking them on every visit, and they may not be motivated for the first 6 months, but something might happen one time when you just say, you know, you're still smoking, what about that? And they might go, yeah, okay, fine, I'm going to try to quit this time.
Can I just add my 2 cents? I find my scariness in asking people too and getting them going, moving is how do I help motivate them and get them excited about it? And that's why I think the idea is really to always bring up what are the health benefits of quitting, why you care about them. The people I talk to that are talking to me now often will say, my doctor thinks I need to quit, they care about me, I have a good relationship with my doctor, and those are the ones I find that have connected with the healthcare provider. So I very much think it's because we're not asking enough to get them to think about it. So,
Judith.
I just wanted to make one more mention. A great way to try to motivate people who may not be motivated is to create a sense of dissonance with them. So to ask them why they continue to smoke. So instead of trying to get their reasons for quitting, to get their reasons for smoking, and then try to show them how those are at odds with some of their other reasons for being healthier or wanting to reduce some of their psychiatric symptoms or be at a higher level of control, and then show them create cognitive dissonance with them. That's been shown to be a very powerful motivator.
Yeah, so for the folks who are watching this, what Judith is really explaining is with cognitive dissidence. And this is one thing you probably have training with or would hopefully ask for. All our staff are trained in motivational interviewing techniques and some cognitive behavioral therapy techniques to work with folks, but that is one of the chief ones, is when you start challenging that and creating that cognitive dissonance, it really does help. But sometimes it takes more than once. It really does, and that's why the big motivation now from the public health guidelines is every single time, even because you'll be shocked. Someday you're going to ask, like, and on the 14th time, they're going to go, oh, you know what, maybe I will this time. And it's like, okay.
So you just don't take no for an answer.
It's a really serious problem, and your attitude seems to be very serious. I wonder how humor might work as a cognitive dissonance device, something like that.
So wondering how humor might work. And again, it's going to depend on the person. One of the things that we do, we use a client-directed, what we call client-directed approach to treatment. So we work our plans are very individualized, and we try to get people hooked up. And that is, and really depending on how many times somebody has quit really affects. Humor is often a big one. We have some coaches who are, I would say that's their core in dealing with some folks.
I think the sobering news is my discussion or my talk, because I just feel like when I talk to people and whatever, it's hard to bring a lot of humor into it, particularly when they're having medical illnesses and all the other thing. But I always try to do the positive things, like if they stop smoking, you know, these are the things you could have. And I have actually 5 slides of ideas of positive things that improve. I mean, I've gone through all the literature, and it's really fun to bring those things up. And they often, have you had anybody say, oh, that wouldn't be a good idea? They usually sense that life would be different and that they need a discussion about it. I think that's one thing. It takes time. And I don't think we are taking the time in medical appointments, probably. I know pharmacists are so busy dispensing drugs. You know, we just don't take the time to talk to people. That's why the ASH line, the coaches, I've just been very impressed with their ability to work with somebody, and if they can change a coach if it didn't work out. So we really want them to be successful.
Yeah, and there's one point that's, we've been looking at these tools that we use for measuring our engagement with clients, and surprisingly, we're hoping we can get some funding for this after the analysis is done. But what we're finding is that when people are in a distressed situation, and this is very counterintuitive, they tend to do better at quitting than people who come in who are doing really well. Because we use some tools to assess where people are when they come in. And one of the things we've discovered is when people come in what we call above the clinical average, they're really doing pretty good in life. And they figure, now's a good time for me to quit. Everything's going well, now's a good time. Those people actually do worse over time than the people who come in serious clinical distress, because some of them have said very clearly, this is the only thing I feel like I have control over in my life right now. So if I can make this work, I can feel good about myself. So, and that's very, when they're told to us that way, it clicks. But it was very counterintuitive when we did the analysis on this. How do we engage people and what do our quit rates look like? We were surprised to find that. But it makes sense now that we look at who we're treating.
I have two questions. How frequent are the contacts with the coaches on the ASH line? And after the initial contact, the rest of the contacts, are they client initiated or?
The protocol for the ASH line, the question being what do our contact protocols look like? We have a standard protocol, which is if you followed it to the T, it's 2 calls before you quit, and that could be if you're quitting next week, you get 2 calls in the first week. So it's usually 2 calls before you quit, 1 call a week for the first 30 days, so the first month, so it's a call a week for the first month. After you've been quit for 30 days, 1 call a month for 2 months after that. Because our goal is to keep people in the program until they've been quit for 90 days. We really use a substance abuse model. So that is the standard protocol. But what we do is we tell everybody what the standard protocol is, and then we will modify it for whatever they need. Because if somebody's quitting for the very first time, calling them once a week is not going to work. We know that. But if somebody's been in our program 17, 18, 19 times, and it happens, then they oftentimes don't need the once a week. They just kind of need the oomph. They know everything they're supposed to do. They need that coach to call. And one of the things, somebody brought this up this morning, our protocol, we call them. It's proactive on our part, because what we find in the research that's been done on quit lines, we reach 80% more people if we make the calls instead of having them make the calls.
And I think we are at the end of our grand round, so I really am thankful for all of you coming and spread the word. And maybe, I know this is tape recorded, that people someplace else will watch it. So thank you all, and continue the efforts that we have to help people. Thanks.
We'll stick